next session, Clinical Gems in Diabetes. I invite the chairpersons to the stage, Dr. T. Jayabhagyam and Dr. S. Shivabalamurugan. Over to you.
First speaker, I call upon Dr. Ranjit Pratap, Senior Assistant Professor, Madras Medical College. He talk about body composition and analysis.
Very good evening, ladies and gentlemen. First of all, I want to extend my heartfelt thanks to Dr. Shanmugam sir for giving me this opportunity. And today's my topic is about body composition analysis. And this is not a new test. This is an older test. It is available, but the importance and utilization of this test is very much less in our clinical practice. Let us see the importance of body composition analysis. And this is my flow of presentation from introduction, basics, and method of assessment, clinical implication, and various practical application can be seen here. Okay, what is body composition analysis? This is described as it is a composition of amount of fat, muscle, bone, and water present in the body. And it can be studied at the different levels, starting from atom and molecule level to the tissue, as well as organ and whole body can be assessed. And in the clinical nutrition, it is mainly helpful to measure fat mass, fat-free mass, and body composition mass. And it helps to understanding various malnutrition like obesity, as well as diabetes and malnutrition, and sarcopenia by giving various insight to know about the causes and to know about the progression of disease can be assessed with the usage of body composition analysis. And these are the various uses of body composition. In clinics, it helps to know the physiological changes as well as to know the disease insight can be assessed, and the nutrition, disease risk, and the guide, treatment, and track the progress of the disease can be assessed with the usage of body composition analysis, and with measurement of various nutrition measurement like fat mass, fat-free mass, as well as bone and body water can be utilized with the usage of body composition analysis. Why we need body composition analysis? It is actually very helpful in the trainers, athletes to know the percentage of body fat distribution, as well as body segmental distribution can be assessed, so that to prevent musculoskeletal injury or various diseases can be utilized. It is not only helpful in the management of disease, and it is also very helpful to prevent the onset of coronary heart disease, as well as blood pressure and diabetes can be prevented by assessing the body composition analysis. And this is the Asians peculiar phenotype. We usually, if Asians have 3 to 5% of excess body fat when compared to the western part. At the same time, we have the increased incidence of cardiometabolic risk when compared to the western part. However, obesity is often judged with the use of body weight. However, it is not true and can be assessed with the body composition, and not in spite of all the BMI with normal, lean, and obese, we have excess body fat index, which increases the cardiometabolic risk. As the age increases, there is a shift in diet pattern, there is a decrease in appetite, there is a decrease in physical activity, and natural body process decreases, and all decreases in muscle mass, and there is increase in fat mass, which increases the cardiac as well as diabetic risk. What are the basics of body composition? As I already said, it can be measured at various levels, starting from molecular, cellular, and tissue level, and these are the various body composition gender-wise. In case of water distribution, it is more or less in both male as female, but in fat, it is little bit higher in female, which comprises around 20 to 30%. In male, it is around 15 to 20%, and proteins are much higher in the male part with 16 to 18%, and in female part, it is around 14 to 16%. These are the, if you want to know about the body composition analysis, we have to know about the various terms that are present. What is total body weight, which includes muscles, bone, as well as fat. What about total body water, which consists of intercellular and extracellular water. Along with muscle, it includes total body water. Dry lean mass is a bone. And lean body mass, which includes muscles as well as bone, and total weight, lean body mass, and fat mass. These are the various components we have to know about body composition analysis. What is fat-free mass? It is a total mass minus fat mass. Then how are we going to measure the fat mass? Fat mass is nothing but it is a percentage of body fat multiplication with body mass. Let us see with an example. And this is a trained athlete who has a body mass of 80 kg and he has the body fat of 15%, so that we can have fat mass will be around 12 kg. Then we have to measure free fat mass by 80 minus 12. It will be approximately 68. Skeletal muscle is a part of free fat mass, it always helps in to support the body function and to prevent various diseases. When there is a decrease in skeletal muscle, there is increased incidence of coronary vascular disease, mortality risk, but it also benefit to reduce the central obesity. However, body fat is present as a essential fat and a storage fat. Essential fat is normally present in various tissue organs and vital for main function of various organs, and storage fat is present in the adipose tissues. What about the use? What are the significance? Skeletal muscles help to control the glycemic control to prevent insulin resistance and supports movements and lowers the frailty risk and increases the act as an energy reserve. However, when there is a decrease in skeletal mass, they have increased chances to have development of heart failure, and 75% of the skeletal mass are present in the arm and legs. And upper digmensional mass is often studied in nutrition, exercise, as well as in metabolic health. Poor diet and lack of resistance exercise during weight loss can cause high free fat mass loss, thereby increasing the risk of weight regain. And this is the example. One on the right side has a lower BMI, on the left side has a higher BMI. However, the body fat percent is both 25%, both in lower BMI and above obese person. So there is a need to measure body fat index. Since there is increase in body fat index, then these both persons are more prone to develop cardiovascular disease even with lower BMI. And this is a visceral fat. It is usually around the internal organs. It is related to the liver. Its main function is to store energy, as well as it has a strong endocrine activity. And there is an increased deposition of visceral adipose tissue. It can cause insulin resistance, type 2 diabetes, metabolic syndrome, as well as increased incidence of coronary vascular disease. And risk association is also risk with diabetes, CVD, overall mortality. Usually, visceral adipose tissue is very much higher in the men when compared to the females. What are the various methods? Starting from basic methods like anthropometric measure, BMI, waist circumference, and waist hip ratio, followed by bioelectrical impedance analysis and DEXA, CT, MRI, and skin fold calibration and others can be utilized to know about the body composition analysis. These are the various assessment model, 2-compartment model, 3-compartment model, and 4-compartment model. In 2-compartment model, which can be measured with the usage of skin fold technique and hydrodensitometer and air displacement method. In 3-compartment technique, which DEXA is very much helpful, and 4-compartment model. What are the anthropometric measure? What are the uses and what are the limitations? We all know BMI, weight minus height in meter square. We can differentiate. However, it has few limitations. It measures only weight and not fat or muscles. So it ignores various factors like age, sex, and fat distribution and fitness. In weight, waist hip ratio as well as weight circumference, it also has a few limitations. It does not measure fat mass or fat-free mass, so not a full body composition has been assessed. What about bioelectrical analysis? It uses low current, electrical current to measure the body resistance and helping to estimate various body composition. And it is a very quick, low cost and non-invasive technique which can be used in either sex to know about the body composition. Since fat is more buoyant, since there is a less water, so electrical will not be passed when compared to muscle which is rich in water, so it passes very quick in the skeletal muscles. The major use, it can measure both body fat and free fat muscles. At the same time, it also can measure segmental muscle as well as segmental fat analysis can be utilized with the usage of bioimpedance analysis. There are few limitations. It is often limited with the hydration, food or alcohol intake and menstrual cycle and electrolyte placement as well as recent exercise within 24 hours may alter the body composition analysis through bioimpedance analysis method. The next one is DEXA. It is an imaging recommended for the clinical purpose. With advanced technology, we can measure exactly the fat as well as the lean muscle mass can be used, and we can measure bone, mineral content, fat and lean tissues. However, it also has a few limitations. It doesn't measure total body water and uses low radiations. When we are going to have good hydration during DEXA, and digestive tract contents can cause lean mass to be overestimated and fat mass to be underestimated. CT, we are used more frequently for measuring visceral fat, as well as these are the various advantages: very fast, enhanced image resolution, 360 degree from head to toe can be measured. It also, what are the clinical uses? It is very much useful in oncology, for staging, monitoring, and surveillance, and can association between the body composition and treatment outcome can be measured in solid tumors and hematological malignancies. MRI, it can differentiate between intermuscular and intramuscular fat. What is the importance of intermuscular fat? It is the main thing to develop insulin resistance, inflammation, and visceral adipose tissue. It is very much helpful in sarcopenia and metabolic health. This is a skin fold thickness measure, can be measured in the OP. These are the various areas can be measured starting from triceps, biceps, subscapularis area, suprailiac, mid-calf, anterior abdominal wall. Out of 3, average one has to be taken. It is usually expressed in millimeters. The limitation are, it decreases in case of severe obesity and requires proper training and skill for accurate measurement of skin. What are the clinical implications? It is very much helpful in obesity, metabolic syndrome. In case of obesity, CT and MRI is preferred. In patient with type 2 diabetes, bioimpedance analysis can be used, or with PET we can use to evaluate the skeletal muscle glucose uptake, and which is a marker for insulin resistance. And regarding cardiovascular risk and sarcopenia, CT is more precise. And in case of pediatric childhood obesity, it is always they have a long-term risk for developing of diabetes cancer. So BMI alone is not going to be very helpful, because it is very simple. Even though it is very simple and common, it doesn't separate between fat by lean mass and by risk by sex or age. So bioimpedance analysis is preferred for higher accuracy and reproductivity. These are the various applications. By selecting the right tool, we have to choose the right patient. It also depends upon the cost, practicability, and data quality. In case of non-invasive portable, bioimpedance analysis can be used with whole body and regional measurement. With last stage DEXA can be used with rapid whole body muscle fat measurement. We can use MRI. The reason one is 3D scanning technology can be used, which is very much emerging and reliable, and it is much cost effective when compared to others. And this is a knowledge gap currently present, limited understanding of body composition with the disease link, and there is a need for large-scale data sets for multiple body composition measures, and support comprehensive risk models can be assessed, and personalized risk assessment model by addressing these various gaps. How we are going to bridge the gap? By doing DEXA, CT, and MRI, which provides high precision and comprehensive data on body composition, health, and links, and bioimpedance analysis and 3D scanning, which is very much suitable for clinical practice and balanced feasibility. And integration of various research and clinical data supports the comprehensive disease risk management. And this is a bioimpedance analyzer, and this machine costs around 1.4 lakhs. And this is the result that has been generated. Let us decode these results, starting from body composition analysis, which includes intracellular, extracellular, and total body weight, soft, lean mass, fat-free mass, and weight can be assessed, which has a normal range also. And then followed by muscle fat analysis also, measured with weight, skeletal mass analysis, and body force analysis can be taken. And followed by obesity analysis, which includes BMI, percentage of body fat, and weight heap ratio can be given in these results. In case of body mass index, it is very clearly says it has a increased body mass or lower body mass, and percentage of body fat can be diagnosed with the usage of these results. Body fat, it usually ranges from, in case of male, from 10 to 18%, in case of female from 18 to 28%. Depending upon the range, we can assess whether the person is having high percent of body fat or not. And not only that, segmental knee analysis, whether the arm he's having good skeletal muscles in the upper arm, right arm, left arm, or in the lower arm, and which will be very helpful for the gym trainers and athletes. And this is regarding total body analysis. Higher the total body analysis, which tells about the swelling, inflammatory, or volume overload state, can be measured with the usage of bioimpedance analysis method. Segmental fat analysis also can be measured with the usage of this. In this, the person is having increased amount of fat distribution in that abdomen, which clearly tells about the central obesity, so that any weight reduction has to be targeted for these patients. Basal metabolic rate can be measured with this bioimpedance analysis, and visceral fat level. Usually the range is 10. When it is about 10, there is an increase in visceral fat level, so that we can start action for reduction of visceral fat. And this is a total body composition history throughout from whether the patient is decreasing the weight, whether the patient is improving the skeletal mass index, and there is a reduction of percent of body fat, whether the patient is having good water content, can be assessed throughout the period. And this is my end of the slide. Conclusion, body composition analysis, it goes beyond BMI because it offers various insight for fat, muscle and bone distribution throughout the curriculum for management of diabetes, cardiovascular disease and metabolic disorders and growth in children as well as in adolescent. And the core components include fat mass, fat-free mass and muscle, with visceral fat playing the central role in impaired metabolism, insulin resistance and elevated cardiovascular risk. And assessment methods starting from various basic anthropometric measurement like BMI, waist circumference and waist hip ratio that can be done in a clinic itself, to the advanced imaging depending upon the patient, depending upon the study, whether the clinical care research, we had to choose the tool, whether we had to choose bioimpedance, DEXA, CT and MRI. The clinical implication integrates risk stratification, tailored intervention and longitudinal monitoring, while patient education and engagement enhances disease prevention, personalized care and optimized use of body composition tools. I once again thank our chairperson and audience for spending the valuable time. Thank you.
Good evening all. Thanks to the organizers. Thanks to Dr. Ranjit for this nice presentation. I invite Dr. Amala Florida to talk on lipid variabilities in diabetes.
I would like to thank the organizing committee of DAISICON for having given me this opportunity. So, among the clinical gems, my topic is on lipid variability in diabetes. So, I'm going to start my talk with a saying by the famous Canadian physician, Dr. Sir William Osler. He said, variability is the law of life. So, as diabetologists and physicians, we all know about glycemic variability. So, we all know that glycemic variability is one of the pillars which gives rise to diabetes complications. But we have to be concerned about variability of other risk factors as well, especially risk factors in diabetes like hypertension, dyslipidemia, even uric acid, BP, all these risk factors in diabetes also have some variability, and this variability is contributing to complications. So while we have been preoccupied with glycemic variability, so a lot of data is emerging saying that variability of the other risk factors also contributes to complications in diabetes. So the scope of my talk is only lipid variability. So most of my slides are going to be on how lipid variability contributes to diabetes complications. So going on to history of lipid variability, so way back in 1960, Gruber et al., they studied 177 military personnel over a period of 5 years. So what they found out was greater fluctuations in cholesterol. Persons who had greater fluctuations in cholesterol, they developed clinical manifestations of coronary artery disease. So there was a long gap, and 34 years later came the Framingham study. So in this study, one of the subgroup analysis, they found that greater long-term intra-individual variability in total cholesterol increased the all-cause mortality in men over a period of 24 years. And not only that, it increased cardiovascular and coronary disease incidence and mortality in both the sexes. Again, the curiosity of lipid variability died down, and then came a very interesting article in this present decade in 2021 by Dr. Antonio Ceriello. So this article threw much light on variability of risk factors and diabetes complications, in which he has dwelt upon the variability of so many risk factors related to diabetes. So I'm going to talk about the lipid variability. So the fact that glycemic variability gives rise to complications in diabetes is well known and well proved by all these landmark trials like ADVANCE, DEVOTE, VAT, all had ACCORD and EMPIRIC outcome. So long-term glycemic variability is correlated with an increased risk of both cardiovascular and microvascular complications, but now there is emerging evidence that long-term variability of other risk factors may be involved in the development of diabetes complications. So what are the major risk factors which are related to complications? Predominantly, Dr. Antonio has dwelt upon blood pressure, lipid profile, heart rate, body weight, and even uric acid. So can you imagine the variability of uric acid also contributes to complications in diabetes? So I'm going to focus on the articles that he has quoted, the studies that he has quoted about lipid variability. So this is the first study. This says that visit-to-visit LDL cholesterol variability is an independent determinant of carotid intima media thickness in patients with diabetes. So they studied 162 patients with diabetes. They were followed up for 1 year. So it was found that LDL variability was an independent determinant of carotid intima media thickness. So this was independent of so many other variables like mean LDL levels, waist circumference, BMI, diabetes therapy and duration, mean and SD of glycemic and other lipid variables, and even use of hypolipidemic and antihypertensive drugs. So LDL variability proved to be a very independent determinant of carotid intima media thickness. Then came this study which says greater LDL cholesterol variability increases the risk of CV events in patients with diabetes. So high LDL variability correlates with increased risk of CV disease in patients with diabetes. And then visit-to-visit variability of LDL, HDL and even non-HDL had an effect on mortality and CV outcomes in patients who have already undergone PCI, percutaneous coronary intervention. So they studied 1,792 patients who had undergone PCI over a follow-up period of 65 months, and 114 developed a MACE in that follow-up period. So among them, it was found that the visit-to-visit variability in LDL, HDL and non-HDL was significantly higher in the group suffering a cardiovascular event after the PCI. So they did a multiple regression analysis, and this LDL, HDL and non-HDL variability parameters, they were found to be independent predictors of CV events after adjusting for a number of confounding variables. So the same held good for the subgroup with diabetes as well. So not only CV disease, even nephropathy has been found to be influenced by lipid variability. So HDL cholesterol was found that HDL variability increased the risk factor for appearance of albuminuria in diabetes. Not only that, the triglycerides. So this study says post-meal triglyceridemia along with HbA1c and post-meal glycemia. It was a predictor for annual decline in eGFR in patients with diabetes with different stages of nephropathy, and variability of triglyceride levels and incidence of microalbuminuria was studied in this study. So high levels of postprandial triglyceridemia and visit-to-visit variability of triglycerides predicts the development of worsening of nephropathy in diabetes. So this is a table which summarizes all these studies about the variability of LDL, HDL, non-HDL and triglycerides. So most of the associated outcomes were cardiovascular events, albuminuria and eGFR decline. So what is the pathophysiology? How does lipid variability cause diabetes complications? So similar to glycemic variability, fluctuating lipid levels cause mitochondrial dysfunction. They elevate the reactive oxygen species levels, causing a chronic inflammatory state. So they cause impaired cell migration, increased monocyte adhesion and induced endothelial apoptosis. So this is a pictorial illustration of the pathophysiology. So lipid variability impacts the mitochondrial function. So inflammatory genes are activated. This leads to endothelial dysfunction and apoptosis. Not only that, when there are fluctuations in lipid efflux, there is a compromise in plaque stability. So there is elevation in risk of the plaque rupture. So we have our continuous glucose monitoring system to measure glycemic variability. But how are we going to measure lipid variability, and what are the metrics? So by definition, lipid variability is fluctuation in various types of lipids over time. And we use, it has two dimensions like mean level and intra-individual variability. And the metrics with which we measure the lipid variability are standard deviation, coefficient of variation, variation independent of the mean, shortly called as VIM, and average real variability, that is ARV. So these are the different metrics of lipid variability. So we saw that lipid variability gives rise to complications in diabetes. So even in the pathogenesis of diabetes, lipid variability can increase the risk of a person getting type 2 diabetes. So it's involved even in the pathophysiology of diabetes. So long-term fluctuations in total cholesterol and HDL cholesterol may increase the risk of developing diabetes, because cholesterol homeostasis is vital for the pancreatic beta cells for the survival, proliferation and functional maturation. So this is the paper, in an interesting article you can go back and refer, which talks about the role of lipid variability in pathogenesis of type 2 diabetes, cholesterol redistribution in pancreatic beta cells. So not only in diabetes, lipid variability causes quite a few issues even in non-diabetic population. It causes cognitive dysfunction, dementia, and even atrial fibrillation. So this is in the non-diabetic patients. How do you manage lipid variability? So prime cause of lipid variability is non-adherence to statin. In fact, LDL variability has been used as a specific clinical test to see if the patient is adherent to the statin or not. So it is a measure of adherence, LDL cholesterol variability. So other causes of lipid variability have to be corrected, like weight changes, chronic kidney disease has to be managed adequately, and genetic factors, they cannot be altered. But we have to bear in mind that these are all the other causes of lipid variability. So a lot of research is going on how to treat this lipid variability. So the PCSK9 inhibitors, a lot of research is going into that angle, whether they can reduce this lipid variability. So in conclusion, from a therapeutic viewpoint, it is time to reduce the magnitude and variability of risk factors in diabetes, and it is time to think beyond glycemic variability. And in the context of my talk, it's time to think about lipid variability. Thank you.
Thank you, Amala, for nice presentation. So, question will be asked at the end of the session. I call upon next speaker, Dr. Vasugi, Associate Professor, Institute of Diabetology, Stanley Medical College. A new topic, hand grip strength, a new vital sign.
Good evening, one and all. At the outset, I would like to thank the organizers for this wonderful opportunity and this wonderful topic, hand grip strength, a new vital sign, which is very new to us. So in the next 10 minutes, I'll be talking on importance of muscle strength in health and diseases, hand grip strength definition and significance, sarcopenia guidelines, sarcopenia and diabetes, and hand grip strength as a vital sign. So what is the importance of muscle strength? So now we are talking about heart, lung, kidney, all these things. But what is the importance of muscle strength in medicine? Is it only for athletes? Is it only for people who are going to gym? Is it only maintenance of fitness level? Or is it anything more beyond that? So importance of muscle strength is mainly because it helps to detect and quantify muscle power, especially neuromuscular and musculoskeletal conditions, which we already know. It is very, very important in diagnosing sarcopenia and tracking disease progression. So by regularly testing muscle strength, clinicians can monitor the effectiveness of treatment for any disease and guiding treatment. It helps in rehabilitation programs, nutrition programs, and for a lot of workouts. And most important is muscle strength prevents falls and it avoids injuries. And more than that, it improves the quality of life, mainly the functional quality. And we all know the bone and joint health. Bone is always dependent on the muscle. So whenever we need a good whenever the bone mass has to be adequate, it is dependent on the muscle strength and muscle mass. And more than all these things, the topic of today is muscle health and chronic diseases. This is very important. We will get to know that it is very, very useful for effective prevention and management of chronic diseases like CVD and diabetes. So muscle strength and chronic diseases. We always think whenever we see a patient, a person who is fit and fine with a 6-pack, 7-pack, we just say that, he's fit. That's all, physically fit. But does it help in prevention of diseases? Does it help in management of diseases? Yes, they do. Diabetes, mellitus, and muscle. It's very, very important, very much interlinked. We all know that skeletal muscle is a seat of postprandial glucose disposal. So skeletal muscle uptake is very, very important for control of postprandial hyperglycemia. So skeletal muscle is closely related with control of postprandial blood glucose levels. And then hypertension, physical activity, CVD. Much has been talked about lipid variability. So CVD, it controls diabetes, it controls hypertension, and it also helps in reducing the dyslipidemia. Obesity. Whenever we have to reduce the fat mass, you have to increase the muscle mass. Anything related to bone, muscle is the first which has to be treated. So joint arthritis, osteoporosis, reduces inflammation. Whenever the skeletal muscle mass is very good, then there is less of fat mass and automatically the inflammation is controlled. Improves lung capacity, very, very important. And it is not only in patients with COPD or bronchial asthma. For normal persons itself, a good muscle strength improves the vital capacity of the lungs, prevents depression, reduces all-cause mortality and cancer mortality, and improves the quality. Finally, it improves the quality of life. And then what is hand grip strength? It is a measure of maximum force that can be generated by muscles in the hand and forearm. So what is the force generated when you're using these forearm and hand muscles? Why we are measuring this? It is a surrogate measure of the overall muscle strength. It is correlated with skeletal muscle mass, function, and overall health. Very easy to measure, very quick and inexpensive. And when there is lower hand grip strength, it is associated with higher risk of metabolic syndrome, disability, and chronic diseases. So what does this hand grip strength measure? It measures the maximum voluntary strength of the forearm muscles used while holding and squeezing. When you're holding and squeezing, what maximum strength can achieve? The whole body skeletal muscle strength is assessed just in the arms, in the hand. It acts as a proxy for overall muscle strength, particularly in the upper body, and is a primary tool in diagnosing sarcopenia. So why should we know this? Why we need to know about this muscle strength? Sarcopenia is a public health problem, not diabetes, hypertension, or CVD. We have so many geriatric patients who don't have diabetes, who don't have hypertension, but who have sarcopenia and osteoporosis, and they have multiple falls, fractures, and not able to move at all. So please remember, from the age of 40, the adults lose 8% of muscle mass per decade. Very alarming. We talk only about heart and kidneys. And then after 70 years, it increases by 15%. The muscle mass, without anything, age-related. And what about the muscle strength? Very alarming. There's decrease in 10 to 15% per decade after age of 40, and 25 to 40% per decade after 70. Unless we do some exercises, we cannot preserve this muscle strength. And the hand grip strength peaks around 30 to 40 years, and subsequently or beyond 40-45, it shows a decline, gradual decline. So grip strength starts declining after 45 to 50 years of age. So what is the diagnosis of sarcopenia? Asia Pacific approach. When the muscle strength is low, we call it as possible sarcopenia. When both muscle mass and muscle strength both are low, muscle mass most important, it is proven sarcopenia. When the performance is less, the patient is not able to walk at all, then it is severe sarcopenia. And you see that all the working groups on sarcopenia, they recommend hand grip strength as the first step in diagnosis of sarcopenia. So if this is normal, then further testing is not necessary at all. The Asian Working Group on Sarcopenia in 2019 recommends using grip strength in dominant hand to express muscle strength. So how is measured? By using a handheld dynamometer, very easy to measure. We can do it on ourselves, we can do it in clinical practice also. Of course, this is a little costlier, but this is a little cheap. So string type dynamometers, Medley, and then hydraulic dynamometers, JAM is the gold standard, and then digital dynamometers, which are very available. So there's a posture, how you should do with Smedley and how you should do with Jamar. So with Smedley, you have to stand and do it. With Jamar, you have to sit and with the elbow bent at 90 degrees. And this is the standard mean of the standard deviations of hand grip strength in all the patients age-wise. So you can see that in men, so it slowly decreases below, after 70. So almost 40s in men, and in women, it is right hand I'm talking about, it's dominant hand. So 30, 31 like this, around 20s and 30s, and after 70, it automatically reduces to 20. This is the hand grip strength. So what does the Asian groups talks about sarcopenia? The muscle strength, the hand grip strength using the dynamometer is less than 28. We saw 30 is normal and 70 itself. Less than 28 kgs in men and 18 kgs in women. Then we can take it as clinical sarcopenia. So sarcopenia and diabetes. So why are you worried about sarcopenia? It is a territory of the orthopedician rheumatologist. I mean, orthos will get more money, if the patient is going to fall down. So why should we worry as a diabetologist? Yes, we have to worry because skeletal muscle is seat of postprandial glucose disposal. So it's a bi-directional relationship. Whenever this sarcopenia is there, the energy metabolism is altered and the blood glucose starts peaking at the postprandial level. We talk about postprandial hyperglycemia so much. We add only drugs. We don't concentrate on the core concept of skeletal muscle. What drug you are going to add? 4 drugs, 5 drugs, insulin. The glucose has to go inside the skeletal muscle. When there is sarcopenia, where will it go? It will stay in the blood only. So sarcopenia impairs glucose uptake, contributing to hyperglycemia. Very important point for physicians and diabetologists. We need to have a good muscle mass for the patients. In turn causes inflammation, oxidative stress, mitochondrial damage, further weakening. So it's a bi-directional relationship. Fine. Does hand grip strength really correlate with chronic diseases? Okay, we're talking about so much. It can correlate with falls, I can understand. What about diseases? Yes, we do have papers. Very important papers. A prospective study. Association between grip strength and incident type 2 diabetes. 1,66,894 participants in the UK were followed up for the period of 5.3 years. 3,713 patients developed diabetes associated that lowest quintile of absolute grip strength had a 50% higher risk in men and 25% higher risk in women. And see about adolescent, okay, leave hand grip strength, sarcopenia, all crossing 70s. What about the youngsters? Yes, does it mean anything for the youngsters? Yes, it does. See, this is an adolescence, age 12 to 19 years, very important. After adjustment for age, physical hand grip strength was inversely associated with fasting insulin levels, and Homaya showed insulin resistance in skeletal muscles. And then associated 2-hour post-glucose, inversely related. Very, very logical, because if there is no muscle, then the postprandial blood glucose will not come under control. So what about the CVD? Healthy young adults. So prediction of lung function with hand grip, yes. And association of hand grip strength with CVD, yes. They say that higher hand grips were significantly associated with decreased CVD, inverse relation. And then when the hand grip strength is lower, then there is increased risk of CVD. So again, so all these point to what? It taking hand grip strength as a vital sign. So comprehensive health assessment. We talk about only heart, only kidney, only lungs, see the saturation, see the blood pressure, right? Take hand grip strength also. Early disease detection for diabetes. Predictive value, yes, it's a predictive value for both morbidity and mortality. Serial measurements, we can do it. Yes, it's very simple to do it. So you give some strength training exercises and do it again. And cost effective and non-invasive. So hand grip strength is a vital sign now. So we always celebrate World Heart Day, World Kidney Day, World Diabetes Day. Let the physicians celebrate World Sarcopenia Day on July 4th. Your grip strength could be a better indicator of life expectancy than blood pressure. Muscle health matters. We only talk about heart and kidney, but muscle health also matters. So, muscle and mother, often neglected by man, but boon from divine to alleviate human suffering. Thank you.
Thank you, Dr. Vasagi, for the excellent presentation. Next, I welcome Dr. Venkatesh, going to talk on dementia and diabetes, hope and concern.
Yeah, very good evening, everyone. At the outset, I would like to thank Dr. Shanmugam sir and the scientific committee for giving me this wonderful opportunity. So, in the next 10 minutes, we are going to have a discussion on the dementia in diabetes. That is the deadly combination. Why it is a deadly combination means it is difficult to manage when it both comes together. So what are all the concerns in managing these two conditions, and also what are all the emerging modalities in managing these two conditions we are going to see. So dementia and diabetes both are the two major public health concerns we all know. The main concern is the rising prevalence of both the diseases. Both diabetes as well as the dementia, the prevalence is keep on increasing, and its association is also keep on increasing, leading to difficult to manage both the conditions. And the kind of hope is that there is increasing awareness among the public as well as the physicians in finding the diagnosis of these conditions, as well as also some research and interventions bring some hope in managing both the conditions. So coming to the epidemiology of this, around 420 million people have diabetes globally. Around 55 million people live with dementia worldwide. Aging, which leads to increased overlap of both these conditions. So more commonly in elderly people only, causing great impact in the individuals, families as well as on the healthcare system also. So overview of my today's lecture is that understanding the link between the metabolic dysfunction and cognitive decline, and exploring the mechanism which links both the conditions and identifies the risk factors and the clinical implications of the conditions, and prevention and management strategies. So coming to the dementia, we all know that is a group of symptoms that affects the higher cortical function, that is affects memory, reasoning and mental task. It is usually the onset is insidious, and its progression is it's a progressive in nature, chronic and progressive in nature, and it's caused by the disturbances in the higher cortical functions like memory, orientation, thinking, calculation, comprehension, learning capacity, judgment and the language. The main population affected by the dementia is mostly the elderly population only. Only 2% of the population affected by the dementia is less than 65 years. So it is one of the most debilitating illness in the elder life individuals. So the serious mental decline that occurs with the dementia is definitely not a normal part of aging. We have to deal with to prevent the further deterioration in the quality of life. Coming to the what is the link between the type 2 diabetes and the dementia? Is there any association between the diabetes and dementia? Definitely it's yes. Diabetes itself is a risk factor for the both development of the dementia, of both vascular dementia as well as the neurodegenerative diseases. Type 2 diabetes is associated with approximately 1.5 to 2.5-fold increased risk of developing dementia in elderly patients. So it increases the risk of Alzheimer's disease, vascular dementia, everything. In many literatures in the 2010, many literatures suggest that Alzheimer's disease is a type 3 diabetes. Because of its, the brain insulin resistance is the key factor. That is that Alzheimer's disease is the type 3 diabetes. Many literature as in the late 2010 claimed that it is one of the type 3 diabetes because the brain insulin resistance is a key factor. But none of the global association, any diabetic or endocrine association accepted this coining of the name, because the brain insulin resistance is not the only key factor in causing the Alzheimer's disease. So the type 3 diabetes, why this? They are clinically, they are significantly, they are mentioning that brain insulin resistance is clearly associated with the development of dementia in the diabetic patient. So other mechanisms also involved. Several mechanisms are associated with the diabetes, and also in the even pre-diabetes stage itself, the cognitive impairment is associated with that. And also the metabolic components such as obesity, hypertension is also associated with increased risk of dementia as well as in the impaired cognitive, impaired cognition. So both metabolic syndrome and diabetes, hyperglycemia, everything is involved in the development of dementia. the other possible mechanisms apart from the insulin resistance are even the chronic hyperglycemia also causes oxidative stress, and the vascular damage also causes microangiopathy, which causes dementia. Inflammation and deposition of the advanced glycation end products also causes the progression of dementia. And also amyloid beta accumulation in type 2 diabetic patient also increases the risk of dementia in elderly as well as in the diabetic patient also. So these are all the different mechanisms of association of diabetes and dementia. We already seen that the vascular pathology, insulin resistance, advanced glycation end product, and that anti-diabetic medications causing recurrent hypoglycemia also leads to development of dementia. Recurrent hypoglycemic episodes definitely is one of the risk factor for increased risk of dementia. So it has to be avoided in elderly patient or at risk patient. So this is the flow chart showing all the factors are involved in the development of the dementia, cognitive disorders and dementia like insulin resistance, hypoglycemia, microangiopathy, hyperglycemia, macroangiopathy, inflammations, genetics and aging, all together involved in the pathogenesis of the dementia and cognitive impairment. So type 2 diabetes itself causes a compromised brain. So type 2 diabetes, by causing vascular damage and metabolic disruption, it induces the oxidative stress, thereby it damages the neuron, causing neuronal dysfunction, white matter damage, atrophy, which finally leads to cognitive impairment and the risk of developing dementia, including the Alzheimer's disease. So this flow chart clearly explains every possible mechanisms involved in the pathogenesis of the diabetes, which leads to dementia. So coming to the concern in managing these two conditions is that the complex mechanisms, we already discussed with that complex mechanism which is difficult to manage and also difficult to assess the progression of the diseases. These complex mechanism which is difficult to assess the progression of both the conditions. So also the cognitive impairment which leads to poor diabetes self-care, which also leads to increased risk of self-falls, hospitalization and also the medication errors. Medication errors means the patient may skip the doses of oral antidiabetic or insulin, or inadvertently took double the dosage of the medicines, leading to hypoglycemia. So medication error is more possible in the dementia patient. So definitely need a caretaker must be needed for a dementia patient. That is giving a greater caregiver burden. So coming to the challenges in managing these conditions means we have to prevent both the hypo as well as the hyperglycemias, and also polypill therapies must be needed to address both the conditions. So and also initial screening is often neglected in the routine screening of the diabetes population. Now cognitive screening is not enrolled in the initial screening. Lack of specialized care in the low resource settings, and cognitive screening is often neglected in the routine screening procedures. So coming to the hope of this, prevention is better than cure. We all know that prevention is possible. Lifestyle changes definitely lowers the risk of both diabetes as well as the dementia. Healthy diet, regular exercises, weight management and mental stimulation, control of blood sugars, blood pressures and cholesterol definitely lowers the risk of both development of the complications of diabetes as well as the dementia risk also. And regarding the newer researchers like GLP-1 receptor agonist and also GLP-1 and GIP receptor agonist, that is tirzepatide, are showing some cognitive benefit. Many ongoing trials are there which shows that it lowers the risk of developing the dementia. Metformin is also linked with the lower dementia risk. Intranasal insulin, brain insulin delivery also having many trials also there, many small trials also there, which shows some hope in reducing the dementia risk. And also advances in neuroimaging and biomarkers, many biomarkers are there with the blood-based biomarkers as well as the CSF-based biomarkers, which will the elevation, which these biomarker indicates the presence of dementia even before the symptoms appear. That is, the blood-based biomarkers are the neurofilament light chain markers and the plasma phosphorylated tau protein. CSF-based biomarkers are amyloid beta, tau protein and phosphorylated tau protein. These are all some of the biomarkers which will its levels, the elevated levels indicates the presence of dementia even before the symptoms appear. We can assess, we can easily able to pick the patient's risk of dementia patients also. So GLP-1 has shown a very neuroprotective effect by inhibiting the oxidative stress, neuronal apoptosis, neurotoxicity, and also it inhibits the deposition of the beta amyloid and tau protein, and also it suppresses the neuroinflammation, thereby having a very good neuroprotective effect, thereby improves the cognition and memory. These are all some of the CNS effects of the GLP-1 hormones, which shows that it has a very good effect in reducing the dementia. It is one of the many ongoing trials. It is one of the therapeutic options in dementia patient also. Many trials are going on. These are some of the meta-analysis trial which also shows that metformin, thiazolidinediones, pioglitazone, GLP-1 receptors and SGLT2 inhibitors, except sulfonylureas, many all other has shown that associated with reduced risk of dementias. And this is another one meta-analysis study also shows that GLP-1 receptor agonist, DPP4 and SGLT2 inhibitors also shown a novel therapeutic approach for the Alzheimer's disease also. These are some of the trials, small trials which has been intranasal insulin, metformin and liraglutide, rosiglitazone, pioglitazone, which shows some promising effect in reducing the risk of dementia in diabetic patient. So coming to the recent two more slides. Recent advances in dementia management is that pharmacotherapy, the anti-amyloid monoclonal antibodies like lecanemab and aducanumab has shown a significant impact in reducing the progression of the dementia, and also the non-pharmacological management, the Mediterranean diet and ketogenic diet. That the ketogenic diet also shows some positive response in reducing the dementia progression with the small trials has shown brings some hope in the dementia management. So screening is very, very important for the patient with the dementia. Cognitive screening in diabetic patient more than 65 years is usually recommended, and MMSE, MOCA scoring are the usual recommended scoring levels. Education for the patients, families and physicians regarding the screening as well as the awareness of the dementia is much need of the hour. And emerging digital tools for monitoring the cognitions. These are all the FDA approved digital cognitive assessment tools. This will easily, we can even without consulting the doctor, we can easily assess the preliminary stages of the mental stages of that. After that we can get a neurologist opinion with this course. So there is a multidisciplinary approach is needed between the endocrinologist or diabetologist, neurologist and geriatrician, mental health professionals. Everything is a collective approach to manage the both diabetes as well as the dementia. So finally, the take home message is diabetes increases the dementia risk. Early lifestyle changes are helpful in preventing the dementia. Avoidance of hypoglycemia is very, very important in the elderly patient at risk of dementia or the elderly dementia patients. Multidisciplinary approach is needed, and ongoing research of GLP-1 and GLP-1 GIP brings some hope in managing both the conditions. Thank you everyone.
Thank you, Dr. Varanges, for nice presentation. I call upon the next speaker, Dr. Raghavan, Assistant Professor, Madurai Medical College, Department of Diabetology, about adult vaccination and its complication. It's a new topic. It's a recent, very important topic.
Respected chairpersons and dignitaries on the days and off the days, a warm good evening to one and all. I thank the organizing committee for this golden opportunity. My topic is adult vaccinations and its complications, especially in diabetes. So before going to the topic, we should know something regarding the definitions of these things. Vaccination and immunization. So vaccination, a preparation that's used to stimulate the body's immune response against diseases. So what is vaccination? It is an act of introducing a vaccine into the body to produce protection from a specific disease. So by immunization, a process by which a person becomes protected against a disease through vaccination. So this term is often confused with vaccination and or inoculation. So why adults should be vaccinated? So in order to protect the vaccine preventable diseases and the severity of the diseases, the patient can be vaccinated. So there are some vaccines are newly arising. So in order to benefit from the newer vaccines, so for example, the COVID vaccine, these are all recently developed vaccines. So another one is to boost the effectiveness of the vaccines, which are already received from the childhood days. So, and the special conditions where during especially travelers and work-related issues to the endemic areas of the diseases, special care should be taken to prevent the specific disorders. So the increased risk of infection in diabetes and other immunocompromised states is hyperglycemia per se is an increased risk factor, and poor long-term control of diabetes is also a factor. So diabetes have decreased immunity, so it has impaired lung function, and there is a chance for pulmonary microangiopathy, and there is increased risk of associated aspiration and comorbid conditions like hypertension, obesity, OSA, whatever the things. These are all the risk factors in diabetes, which are essential for the worsening conditions. So these are the must-have vaccines for diabetes. Pneumococcal vaccines, influenza vaccines, hepatitis B, tetanus, COVID, herpes zoster, and respiratory syncytial viruses. So I am going to discuss on case scenario basis. So these are all vaccines types. It may be a component vaccine or a whole vaccine. So case 1, a 60-year-old male presented with a fever, altered sensorium, breathlessness, 2 days duration, very short duration with a history of diabetes under regular treatment with OHCs. So on examination, there is right infrascapular crepitations, and the CT shows there is consolidatory changes. So what will be the diagnosis? So it is about streptococcal pneumonia. So whether this patient should be vaccinated? Yes, pneumococcal vaccine. So this vaccine is essential for these patients to prevent the fatal complications of this streptococcal pneumonia. So the pneumococcal vaccines, maybe it's a polysaccharide component or a conjugate component, and the conjugate components are not available in India. There are 13, 15 and PCV 20 are available, and the polysaccharide includes PSV 23. So when we compare the potency of these two, the PCV is superior, 73% superior in efficacy against the disease, and the mucosal immunity and herd immunity, these are all superior than PSV. It also have a greater advantage of priming the immune system. Okay. So what are the doses can be, the 2 doses can be given. The first dose of PCV followed by another dose of PSSV 23 with an interval of 1 year. So the booster dose can also be given after 5 years of previous immunization. So next, another second case, a 52-year-old male staying in a refugee camp, known case of diabetes and under oral drugs. So he had a history of acquiring chickenpox from his grandson, who has been suffering from chickenpox for the past 4 days. And there's no history of chickenpox in the childhood. This is the scenario. So he is from a refugee camp. So is he need a vaccination to him? Yes, of course, we should vaccinate against this patient with varicella vaccines. So the recommendations for this includes, so all adults without any exposure of immunity previous exposure of immunity should receive two doses with the 4 weeks apart, and pregnant women also should receive the same 2 doses. And the live vaccines can be contraindicated in pregnancy. The close contact people should receive the vaccines, especially people living in crowded areas, especially military persons, hostlers, teachers, and immigrants, refugees, international travelers should all receive this vaccine. So 2 doses, children 2 doses at 12 months and 4 years. So for the adults 2 doses 4 to 8 weeks apart. And with the timing of the varicella vaccination, if the patient presents within less than 5 days of before exposure, we can vaccinate. So the effect will also be effective. So if it is more than 5 days of duration of exposure, so we have to wait till there is no active infection, then only we have to vaccinate. And the one important message is we should not vaccinate in active varicella infection. So the vaccines available are these 2 vaccines are available. So the live attenuated single antigen varicella vaccine, and another one is MMRV. So the case 3 is 46-year-old man with known case of chronic kidney disease, patient presented with the volume overload state. So he is under regular maintenance of dialysis also. So should we vaccinate? So what vaccination can be done? Yes, hepatitis B vaccine. So for unvaccinated adults less than 16 years of age without any evidence of prior infection. So one important thing is whether the patient is already exposed to that particular virus or whatever may be the thing is very, very important before vaccination for all kinds of vaccines. So for adults, all other adults with diabetes or other comorbid conditions, those patients with DKD, CLD or on RRT therapy, all these patients should receive this hepatitis vaccine. So the effectiveness of the vaccine decreases with aging. So these are the vaccines available, recombinant vaccines. So there are, and combination vaccines. So 3 doses may be given, 0, 1 and 6 months. So another 4th case, it's a 25-year-old primate presented with history of fever, sore throat. Her father-in-law had history of fever, sore throat and cough for short duration of 2 days only. He's a known COPD patient. On examination, the sputum gram staining negative and culture will be negative and CBC is also normal. So it rules out these things. We should suspect some viral lesions. H1N1 RT-PCR is positive. So he was started on oseltamivir 75 milligram for 5 days for suspected flu. Whether this patient needs any vaccination. Yes. New vaccines are produced every year in view of the antigenic drift of the viruses. So he has to be vaccinated every year. Depends upon the situation. So it may be cell cultured or recombinant or live attenuated. So in India, the trivalent and quadrivalent vaccines are available, and currently recommended recombinant and live attenuated vaccines are also in use. So this is the choice of the vaccinations. So among them, so live attenuated or killed vaccine or a recombinant one. So live attenuated, they have very poor response when compared with other things, other vaccinations. So these are all the high risk age groups. These patients, especially we should not use this intranational live attenuated influenza vaccine. So they are the children less than 2 years and adult more than 65 years, pregnancy and healthcare associated persons and with other medical comorbid conditions and other chronic medical disorders. So all these people are differed, especially this live attenuated intranational this vaccine. So other things can be given. So patients with the diabetes more than 6 months of age should receive influenza vaccine yearly. So ADA advises that individuals with diabetes should not receive the intranational, I have already told. So this is another case, 13-year-old boy. He has his dengue infection 2 years back. His NS1 is positive and IgM is positive. The patients are worried about their recurrence. So what to do? So for dengue, there are 4 strains are there. So 4 distinct related viruses can cause dengue fever. So recovery from one will give lifelong immunity to that particular strain alone. So a second infection by the other strains may cause severe dengue shock syndrome like picture. So what to do? So we should give the vaccines only to the previously infected seropositive individuals only. So we should not give the vaccine to the seronegative individuals. If they are again given this this vaccine, so this will cause severe DSS syndromes. So vaccination prevents severe dengue and dengue shock syndromes to the previously seropositive individuals. So 9 to 45 years, 3 doses, 0, 6 and 12 months duration, we can give 3 doses. So this is another case, 24-year-old postgraduate students, so he is going for rural posting, taking food, water, everything outside. So what to do? Whether he needs some vaccination. Yes, typhoid vaccine can be given. Yes, typhoid vaccine, it may be a live attenuated vaccine or a killed vaccine. So the dosages are the Typhoral 21A, 4 doses, and the repeat dosing with every 5 years. The capsular polysaccharide vaccine, only single dose, and repeat doses may be every 2 years. So case 7, so 45-year-old businessman, he's have a history of mild COVID infection in 2020, whose RT-PCR is positive. And he completed 2 doses of Covishield 2021. So he are planning to go abroad and he want to get the recent COVID vaccination. So he asked what to do. So how can we give the vaccination? Does he need a booster dose? Yes, the choice of the booster dose, he has to be given booster dose and mRNA vaccine will be the choice. So booster dose is recommended for the adults more than 60 years and adults with comorbid conditions and travelers and healthcare workers. So even though he has been exposed to 2 doses, protection from both natural infection or the virus wins over a period of time even after strong herd immunity. So it also decreases with aging. So the available vaccines there are the 4 vaccines available. Among them, the Pfizer Moderna vaccine, that is a recombinant RNA vaccine is usually advised, and other vaccines are displaced. So recently, these Omicron adapted booster doses of this, they have been developed recently. So the complications, when you think of complications about these vaccinations, whether this vaccination can cause intravascular thrombosis, vasculitis, or vaccine-related GBS, or sudden cardiac arrest, arrhythmias following COVID vaccination. These are all under gray zone only. So documents and further evaluations are needed for sudden cardiac deaths, whether is it due to the virus itself or the vaccine-induced complications are not still not known clearly. So this is another case. A 63-year-old female. She has severe blisters on her back and chest. She has severe burning pain in the back. That is post-herpetic neuralgia. So she asks, can this happen again? How can I prevent it? So recurrence of herpes zoster can occur. So we can give zoster vaccine 2 doses 2 to 6 months apart. So recommendations in immunocompetent more than 50 years of age or immunocompromised with more than 19 years of age. So in diabetes, this vaccination will reduce the risk of herpes zoster further, and also it reduces the risk of post-herpetic neuralgia. So when you think of these complications of following vaccination, these are the common complications: pain where there is at the site of injection, fatigability, intense headache, and myalgia, chills and rigor. So these are all some common complications. So this is another case regarding the vaccine-induced complications. This is 32-year-old female presented with vomiting, headache, blurring of vision, and Symptoms started 12 days after first dose of Covishield. So this is the picture of CT brain, shows intracranial hemorrhage. What is the diagnosis? And his platelets are only 25,000 cells per cubic millimeter. Yes, this is called vaccine-induced thrombocytopenia and thrombosis. So it may be a acute incident or it may be a chronic inflammation, chronic incident. So acute vaccine-induced acute VITT, it may be due to, first it starts with the thrombosis, it usually often at unusual sites. So it will be in the deeper regions. So there will be definite thrombocytopenia and there will be elevated D-dimer and low fibrinogen levels. And there may be monoclonal gammopathy with there will be antibodies against platelet factor 4 antibodies will be there. So the onset is usually 4 to 30 days following the triggering agents. And the other things includes neonatal stroke due to displacentally transmission of anti-PF antibodies. So these are all the conditions, these are the complications following vaccinations. So how to treat this VITT? So our natural way of treatment includes immediately we heparinize or we'll go for platelet transfusion. So these two things should not be done for this patient. So it will worsen the condition because it will stimulate again the antibody and the things, and it increases the risk of hemorrhage and thrombosis. The first line treatment includes oral anti-factor 10A inhibitors, Uraxaban, Apixaban and Endoxaban, or intravenous immunoglobulins 1 gram per kg, depends upon the body weight, for at least 2 days can be given. So this is another case, 48-year-old male, weakness of both limbs, over 5 days, weakness ascends to involve the arms. On examination, there will be absent reflexes and NCT shows demyelinating neuropathy. And there is a history of 2 weeks back he has received influenza vaccine. Yes, diagnosis, yes, vaccine-induced GBS. So the mechanism may be immune cross-reactivity or molecular mimicry. So the answer is 1 to 6 weeks after vaccination. So this is common following this influenza, meningococcal vaccine, rabies vaccine, adenovirus and other COVID vaccines. So you should not use further use of the same vaccination again. So there is a concept whether the infection related GBS is more common or the vaccine induced GBS is more common is still questionable. So these vaccines are recommended for the patients traveling to the Indians. So these things are given, and the students who are traveling from India to abroad should receive the routine vaccines, DPT, hepatitis, influenza type B, human HPV, influenza vaccine, MMR vaccine, meningococcal, pneumococcal, polio, rotavirus, tuberculosis and varicella. So recently there's a called Euromune vaccine. So this is an oral vaccine used for the prevention of UTI, Euromune. So this is composed of the inactivated bacterial components of UTI, E. coli, Klebsiella pneumonia, Proteus vulgaris and fecalis. So this is a yellow colored. So usually it is administered for 3 months, administered 2 sprays of pineapple flavored suspension usually under the tongue. So it is continued for 3 months. So the final slide, take home message is, so better glycemic control will give you a better immune response. So don't withhold vaccines in uncontrolled diabetes. So only after controlling diabetes only we should vaccine. So don't do it. So vaccination is a part of diabetes care, and the travelers, immigrants and healthcare workers need special precautions. So thank you. Don't hesitate. Let's vaccinate. Thank you for the patiently hearing.
Thanks, Dr. Raghavan sir, for this excellent presentation. Any questions from the floor? With this, we will conclude the session.